It's not my technique, but I mean, we applied our technique to our patients. But I'd like to acknowledge especially the work of Helen Anwander, who was with us in 1 year in Ottawa, over a year actually, and she really kind of pushed that forward for us. So, and obviously our radiologist collaborators, Dr. Radcraw, as well as Gerd Melkus, another PhD, and then one of our residents. So we've already broached that subject that CAM-FAI has been long recognized as a cause of osteoarthritis, as well as described as the pistol grip deformity. The question we're coming at is that how to best assess a result. Do you look at reoperation? Do you look at cartilage progression of arthritis, decreasing functional scores, and also even just these improving functional scores, are they good enough? And ultimately, should we not alter the natural history of the disease process to, in order to fully provide the quality of care that we need? A biomarker can be quite useful for that, as both a diagnostic, which can give us some insight into the pathomechanism, as well as a treatment at a more sensitive level. We decided to look at the T1 sequence because it has a non-contrast and felt that it could be an area that could be easily applied. The T1 is inversely proportional to the proteoglycan content, so the lower the signal, the better the quality of the cartilage, and vice versa. So we decided to proceed with this, and the objective was to look at regions of interest for the joint, looking at cartilage damage, as well as correlation with functional scores, both pre-op as well as post-op. So diagnostic criteria, it's a similar cohort of FAI diagnosed on CT scan with these cutoff values of 50.5 at 3 o'clock and more than 60 degrees at 1:30, with clinical symptoms of pain but no gross evidence of arthritis on the plain x-rays. Patients had to have bilateral cam deformities with only one side being symptomatic. So the idea with that was that each patient could serve as their own control in terms of when you would compare both hips potentially. So a total of 22 patients were recruited, mainly males. WOMAC and WHO scores were looked at. And then a subgroup analysis was done of 13 who underwent the T1 after surgical correction, and all the patients had a chondro-osteoplasty of the head neck junction. The T1 we took the segmentation from the raw data. T1 map was then done. It was multi-slice data to create the segmentation area, and then from that we then created these regions of interest on the side of view, looking at the anterior divided into 6 zones, and then posterior superior into 4 areas, and then as well as going from lateral, intermediate to medial. And the big challenge with that was which slice do you pick and which combination of slice do you pick. And I think as you get more into this aspect, I'm sure young Joe's very well versed, but for us who were novel in this, you're kind of starting to figure out, you know, you can introduce a lot of variability if you don't standardize what you're looking at. So we kind of looked at that, and it took a fair amount of time to work on this. We looked at a bilayer. We didn't try to separate two because it was at 1.5 T. So we didn't have enough resolution for the pixels to really make it a useful analysis. And then we did standard statistical test analysis and looked at correlations between the T1 and the scores. So when we look at the both hips, we just published this in Osteoarthritis and Cartilage, and we had 19 patients in that group. So again, bilateral cam, only one side symptomatic. The alpha angles were not significantly different between the two. And what we found is that there was no significant difference in the overall relaxation time between the symptomatic and asymptomatic side. And then when we did a ratio to minimize interpatient variability, again, that looking at the anterolateral quadrant, we found no significant difference between the two. We also couldn't really establish a strong correlation between the T1 and the alpha angle in that subgroup. And this, not sure we can discuss a bit more. It may be related to some of the cartilage loss occurring anteriorly, and, but there are other correlations that I'll show a bit later. And when you looked at then the whole cohort, looking at T1 versus the pre-op WOMAC score, Slide's a bit small, but there are significant correlations mainly to the anterior superior lateral area, as well as the intermediate slices going from lateral to medial with the T1 Rho values. And then the correlation goes higher when you use a ratio, so that you kind of eliminate a bit that interpatient variability. So when you use the ratio, your correlation goes up to 0.7. And then with the over total WOMAC score, as well as pain and function. So there is some good correlation between the disease state on a WOMAC score and a T1 Rho, which provides some validity to that cartilage mapping technique. Then when we looked at the pre and post surgical correction, we had significant decreases in T1 Rho at the lateral area of the area with the impingement at the anterior superior area, which kind of is something you'd like to see so that you have a positive impact on the health of the cartilage with your surgical intervention. What was interesting is that the percent change in your T1 Rho in terms of improvement was significantly correlated to the pre-op value in T1 Rho, meaning that the more likely you had good you maintained cartilage, your improvement was more significant, both in the anterior superior and posterior superior quadrant, so that the pre-op state has an impact in terms of your capacity to have a change in your T1 Rho or maintaining of your cartilage health, which again gives good face validity to that technique in terms of cartilage assessment. We're able to find a significant correlation in that surgical group with the alpha angle, but that was in the posterior superior quadrant. Again, this may be related to the capacity to do the matrix and the segmentation in the anterolateral quadrant, which is affected by potentially the mechanical damage of the delamination, making it difficult to get good resolution. But certainly at the posterior superior, there was a significant, strong correlation between the T1 Rho and the alpha angle. And then when you look at correlation with functional scores in the surgical group, again, a very strong correlation between the change in T1 Rho and the change in the WOMAC scores, both on the total and the pain score, and at both the lateral and even comparing all the regions. So again, showing the potential prognostic aspect of this technique to assess patient outcome. So discussion, as mentioned, there was a significant decrease in the T1 Rho in the lateral third of the anterior superior quadrant post-surgical intervention, suggesting some change, or I guess we'll just change alteration. I don't think we can say reverse, but alteration in the degenerative process. These are similar findings that have been shown with degenerate for dysplasia and PAO, as well as the WOMAC correlation. There was, again, a strong negative correlation between the pre-op T1 Rho and the potential overall change. Again, validating the fact that depending on your cartilage status, initially pre-op will have an influence on how you can improve. And finally, there was a significant correlation between both the pre-op and the surgical changes on the WOMAC score with the T1 Rho. Again, at the anterior superior quadrant, which is consistent with our intraoperative findings at the time of cartilage surgery. So in conclusion, we feel that cartilage mapping using T1 Rho is a viable biomarker in the assessment of and treatment of camp-type FAI. I think it offers significant advantages. It doesn't need contrast, a bit more focus on proteoglycan content versus collagen, but obviously further studies in the larger groups are required. Thank you very much.